An influential group of doctors in Canada say it is time for a new way to think about obesity and ending this simplistic idea that people can simply lose weight if they eat less and move more. So let's dig into that for a closer look. I'm Lee Kelso, and if we haven't met, this is HealthCall Live Online, featuring extended interviews that we cover each week on our HealthCall Live Radio Hour broadcast. You know, even more than the USA, Canada faces a public health crisis centering on obesity. So let's jump right into that with Dr. Sean Wharton of the Wharton Medical Center from Burlington, Ontario. An MD played a leading role in development of these new guidelines for physicians to follow as they treat obesity as a chronic disease, not a problem of appetite control. So that's pretty interesting. Tell me more about what makes this a chronic disease and how the doctor should think about it differently.
Right. So the main thing that we want to emphasize is that this is a disease, the same way that high blood pressure and diabetes and other medical conditions are. And what we have not focused on is the biology and the pathophysiology that's connected with this. People mainly want to focus on willpower, the fact that you need to stay on that diet a little bit longer. You need to exercise more. And those are biases that many people in the community have. Now, when we start to move into the biology and the physiology, we move away from bias and we move into appropriate medical treatment, the same way we treat other chronic medical conditions.
So tell me more about that. I'm really curious about your thinking that we have a set point in our bodies that our bodies just want to be, and we need to think about the best weight versus kind of what a height and weight BMI chart tells us.
Exactly. So we know that the BMI as a measurement of someone's weight is flawed. So when we look at it as a measurement of disease, it's definitely flawed because all it tells us is body size. It doesn't tell us the health of the individual. So what we are trying to focus on is get away from BMI, move to whether a person has excess fat cells that are causing an impairment in health, toxic fat cells, in fact. And mainly, the toxic fat cells sit in the central area. And that can cause inflammation that goes to multiple parts of the body. And we know certain people are more predisposed to having central fat cells than others. So white males, South Asians, the indigenous population put a lot of energy into the central area, whereas African American females oftentimes put their energy into the peripheral fat, which doesn't cause metabolic disease. And that's in the thighs and in the hips.
So are you talking there about the abdominal fat that we often see that when you thump your belly, it's hard like a melon, that kind of thing?
That kind of thing. So that is called the downtown fat. The fat that's in the downtown area is more of a problem. The fat that is in the suburbs, which is in the peripheral area, isn't as much of a problem. The challenge is in America is that a lot of people start to get so much weight that they move from just the peripheral weight to also central weight. So the people who just mainly put energy into the peripheral areas, like I said, African American women put it there first. But then if their weight goes up and up and up, guess what? They're going to start to put it in the central area also. So they are now at increased risk of diabetes, heart disease. So that's important to know.
So this downtown fat is more hormonally active, I understand, and you said it creates inflammation and other things. Is it possible to be fat and healthy at the same time?
Yes, it is possible. It's absolutely possible. So we know that, again, let's go back to the same scenario that we were just talking about. African American women do not run into a real metabolic problem until their BMI is over 32. Once over 32, things can go a little bit south.
Yeah, and if you haven't checked your BMI, I encourage people to do that. It's very simple to do. There's a million calculators online. It's a factor of your height and your weight, and you'll figure out what your BMI is. Always just a good number to know. So talk to me a little bit about this whole idea of your body resisting weight loss, that everybody's body has a set point, and that explains the whole idea of yo-yo diet results.
Yeah, so research is still happening in regards to the set point. But what we know is that the set point is in the brain. It's in the hypothalamus of the brain. And we actually see that inflammation that comes from the fat cells can go to the hypothalamus and cause scar tissue. And so if you get to 250 to 300 pounds, there's scar tissue there that's stamped in the hypothalamus. And then as you start to decrease your weight from 300 to 280 to 250, the brain says, you know what? I really want to get back to that 300-pound range because I've got scar tissue there. So you're always battling against the set point within the hypothalamus. Now, we don't know whether that set point is determined when you're first born or whether it's determined because of the environmental influences. But we know that as weight goes up, whatever highest weight you've got to, and you've been there for a good amount of time, a couple of years, that is your new set point.
I see. So what are these environmental influences you just mentioned? What should I be paying attention to?
Well, there's so many. There's the one that is most obvious that most people think about is the fact that there's many more caloric dense foods now available than there ever were back 50 years ago, 100 years ago. That one's easy. We know that. But there's also a number of other things, such as the use of antidepressants, which cause an increase in weight. The fact of maternal age. So if a woman gives birth in her mid-30s or close to 40, she's at higher risk of having a child living with obesity than if she gives birth at the age of 18 or 25. So that's just a little bit of an example of three things that I've talked about that cause an elevation of weight.
So your article in the Canada Medical Association Journal has this line, and I'm going to kind of quote it here so that I get it correct. The crosstalk between homeostatic and hedonic eating is influenced by meditators from adipose tissue, the pancreas, the gut, and other organs. Okay, so I get that. Adipose tissue is fat, right?
Yeah.
So what is homeostatic and hedonic eating? What's the difference there?
Okay, so those are two important parts of the brain. So every day our homeostatic mechanism ends up kicking in. So that's just called hunger, regular hunger, because you haven't eaten for a number of hours. And the brain is craving instant sugar. It's craving energy. So that's homeostatic energy, where your body is trying to stay stable. So static means stable. So if you are 170 pounds and you need a certain amount of food, then the body's, and you haven't taken in your 2,000 calories, at 1,800, you're still going to be hungry and it wants a few more calories. That's stasis. And then we have the hedonic part of the brain, which is the first part of the brain that was developed. So it's always working, it's active. And that's a part of the brain that likes pleasure. And it likes to eat excess food over and above what the homeostasis says. It says that I really like this sugar sweetened calorie dense food and I want more of it. And that excess that we use that is there, why is that part of the brain even there? Well, we know that you needed to have that back 1,000 years ago because you need to pack on extra weight because a famine was coming. So you had to eat above your stasis to have extra calories. And that part of our brain is still working and causes a lot of problems for us.
Okay, I got that. So what is the fix for that? How do I approach that hedonic eating? Because you're really talking there about appetite control and appetite regulation, right?
Right, exactly. So how do you control hedonic eating? Hedonic eating is primarily controlled by the executive lobe. So we've now talked about three parts of the brain: the homeostatic part of the brain, stasis, the hedonic part of the brain, which says pleasure and I want extra food, and then the executive lobe. And the executive lobe has an ability to control both the homeostatic, but more so the hedonic part of the brain. But the thing about the executive lobe, that frontal lobe part of our brain, is that it only works sometimes. It works in the morning. It works when we've had lots of energy, lots of oxygen, lots of sleep. But it doesn't work when our brain has been used up a lot. Later on in the day, if our brain has a ton of stress that is actually happening and using up all of those brain cells, then it stops working and the hedonic part of the brain takes over. So that's where we run into trouble. Evening eating and stress eating.
Yeah. Okay. So how do what is your new paradigm, guidelines telling physicians about to help me cope with all of the things that you just described?
Terrific. So what we need to do is we need to make better connections between the executive lobe and the hedonic lobe and the homeostatic lobe. So those connections in people living with obesity are fractured. And we know that they're controlled by neurochemicals and hormones. So how do we get these neurochemicals and hormones to work even better? So we've got three main mechanisms that we can actually do that with. One is bariatric surgery. So weight loss surgery changes the neurochemistry, allows the connections to be better, allows the executive lobe to exert control on the hedonic system so you don't have cravings and don't have excess hunger. The other is the use of medications. So pharmacotherapy and medications help to change that hormonal level, the neurochemical level, dampens those cravings and the hunger, and says to the body, use your storage. You've got a lot of energy stored there. Use that. Don't look for extra food. And the final is psychological intervention, cognitive behavioral therapy, which strengthens the executive lobe so that it can overpower the hedonic and the homeostatic system.
So, man, you are really talking to me. My nerd brain really likes this thinking. I like the science behind all this. I can tune into it. But that's not going to work for everybody because not everybody's a nerd like me. So how do we get to those folks?
So, and the way that we get to those folks is by having an appropriate medical intervention. So the physicians, doctors, and the healthcare teams need to know that this is a medical condition the same way depression was a medical condition. And we use medications and we use counseling. So we use those two things and they work very well. And doctors end up coordinating that. The patient doesn't do it. They don't go out and make medications or do counseling. So here we have the same thing. Living with obesity, you should be talking to a physician and a healthcare team that can help to address these problems. They can direct you towards appropriate bariatric surgery. They can direct you towards the appropriate prescription pharmacotherapy, the medications that actually work. They're not over the counter. None of those over the counter medications work. These are real medications, prescription-based medications, and they can also introduce counseling and psychological intervention. So that's how you get this treatment, is by engaging with the medical professionals.
Okay, so let's talk about those medications. What are they, and should I be, if I'm overweight, should I be asking my doctor about it if they don't suggest it?
Right. So I think that anyone who is dealing with an impairment in their health because of the elevated weight, if that is your position, then you're in a position where looking for treatment is a good thing. So what are the medications? So the medications that we have right now in Canada, they're a little bit different than the ones in the States. In America, they have a few more. In Canada, we have just a couple of them, but they actually work very, very well. So the ones that work the best, in my opinion, are GLP-1 analogs. And this is a hormone that we naturally produce within our gut. So after you've eaten food, a hormone goes from the gut, from the small intestines, and goes to the brain and says that I've just eaten food. I should stop eating. So the unfortunate thing is that people living with obesity don't have enough of that hormone. So when we give the hormone, it allows people to get full faster, and they are not as hungry, and they start to use their own fat cells to actually for actual energy. So that is one medication. We also have another medication that's a combination of an addiction medication that we use for alcohol addiction or smoking addiction. So you can see that food addiction can be part of that. So this addiction medication tends to work really well. It combines with the antidepressant, again, working in the brain. And those two things work in the brain really well to shut off some of these excessive neurochemicals that are saying eat, eat, eat.
Okay, so my physician has to be up to speed on all of this, and I understand that's what your new guidelines are encouraging doctors to do, right? If I'm dealing with a physician who doesn't really get it yet, and they're still stuck in the, just eat less, exercise more, you'll be all right mode, what do I do?
So with that, what I would do is I would bring them these guidelines. So what we did with these guidelines, they're primarily for the primary care physician. So they're for doctors and for the healthcare care team, because we know that obesity affects so many people that we can't leave it up to just a couple of specialists to actually do this. So we wanted primary care teams to all be able to actually do it. But if they have not read it, if they're not engaged, if they don't know about this, we also wrote the guidelines for the patient. So the patient can take this document and put it in front of their physician and say, there's information here in this medical document. This isn't something I just randomly found off of Google. This is a guidelines with evidence-based medicine, and it says that I can be treated. It says that there's some hope for me. Can you please look at some of this and advise me as to whether any of these medications are appropriate for me, because I'd really like to get some proper treatment.
Loss is possible with this protocol, with these guidelines. Is that just too individualized, or can you generalize and say we see a 10, 20, 50% weight loss?
Yeah, so it is a individual thing, but there are averages. So we know that the most effective is weight loss surgery. So we can see there between 30 to 40% decrease in weight. So we're talking about 100 to 150 pounds. So, and again, it's not because it makes the stomach smaller and you can't eat enough food. It's because it changes the neurochemistry in the brain, where the real pathophysiological problem is. So when we look at medications, we get about 10, maybe up to 20% weight loss. So that's very positive for a person. And although sometimes 5% or 10% doesn't seem like a lot, it makes a big difference to a patient to go down 10, 15% and not be hungry, because they've gone down 10% before, but they were hungry and they had challenges. Now they can go down, not face the hunger, and continue to keep that weight off over the longer term. Psychological interventions are there for everybody. So they can be used on a regular basis, and the amount of weight loss with psychological interventions, which is learning how to deal with coping mechanisms, etc., vary from all the way from 3 to 5% on the lower end, all the way up to 25% if it's with the right combination of treatment options.
What has been the response of the medical community? These guidelines just published; they're very fresh. Well, what kind of feedback are you getting?
We're getting a lot of positive feedback. Of course, that's what I want to say, because I'm the lead author on it, and it's been really great. People, and the reason why we're getting positive feedback is because everybody's aware that we've been treating the disease of obesity very poorly. We've done a bad job. The world has done a bad job. Doctors have done a bad job. Teams have done a bad job, and patients know this. They know that things have not gone well, and now it's time where we're saying that it can go well. Somebody comes into my practice living with excess weight and it's causing impairment in health, I'm confident that I can treat it. I would not have been confident 15 or 20 years ago. At that point, we didn't even know what some of the neurochemicals were, what some of the hormones and the biofactors were. Now we know what they are. We're learning more, but we know what they are, and we know that there's effective treatments. I now have confidence, whereas previously I didn't.
So physicians should be asking for permission to discuss the weight problem with the patients. That's got to be a tough one. It's probably easier to talk about cancer than it is being overweight.
Right. Yeah. And the reason why we tell physicians that it's a good idea for them to ask permission for their patient to talk about weight is because it is a very personal topic. It's an emotional topic. And if a patient is there for a different condition, a different medical problem, then just saying that this is all your weight problem, you need to lose weight and eat less, exercise more, that is paternalistic. It is demoralizing, and it's not a good patient interaction with a doctor. So deal with the patient's medical condition, and then you can say, weight may also be a factor. Is it okay if we talk about weight management? Because I'm confident about treatment options that can actually help you. That's an appropriate way to start a conversation. The other ask I think the doctors should do is they should say, is it okay if we talk about other options besides diet and exercise that can bring this weight down? Because I know that there are options above diet and exercise that would be effective for you. So we're having a new conversation, a better conversation.
So I like this. So we now believe that it's not simply a matter of being weak-willed. It's you are physically unable to control your appetite because of what's going on in your brain, and we need to address that. I think that's going to appeal to a lot of people. What didn't I ask you that you want people to understand about these guidelines or about starting their journey to becoming a smaller human?
Terrific. That's a great question. I think one of the main emphasis is understanding bias. And that's our first chapter in the guidelines, is understanding bias and stigma. So what is bias and why do physicians and patients sometimes have it? It means that if you look at a person who is 300 pounds and you say they don't have enough willpower, their compliance is low, because clearly their compliance is low, they're not following the actual diet, why don't they just do better? That means that you're biased. And it doesn't necessarily mean that you can fix it. We can't always fix our biases, but we can not act on them. And our ability to not act on them is to act on the science and the biology. So regardless of how I feel about it, I'm going to say there's biological and physiological evidence that says that I can treat this, we can treat this. So let's talk about that. If you don't use the biology and the evidence, and you only use your bias, you're going to present in a paternalistic standpoint, which is shame and blame. You're going to point the finger and you're going to say you really should be eating better, getting that weight down, staying on that diet longer. That's bias turned into stigma. And we really need to watch and monitor that. Patients even have internalized this. I don't have enough willpower. I am bad. I am not compliant. When in fact, their disease process in their brain is causing much of this problem. So we need to relieve them of that blame, let them know it's biology and pathophysiology, and help them to get on track, still while doing the healthy eating. So we haven't gotten rid of that. They still have a responsibility, but they now can get additional help because of their disease process.
Well, Dr. Sean Wharton, thank you very much. Appreciate your time this afternoon. A new way to think about obesity and the fight against fat. It's certainly helped me. I learned a lot. Appreciate you joining us.
Absolutely. Thank you.